Every quarter, Keystone Peer Review Organization submits a report to the Bureau based upon their review of the claims in that quarter. And every quarter they submit this report, and it's got a lot of data in it, but it also has some raises some of the issues that they found that quarter in the claims that they reviewed. And some of the things that come up almost every quarter I put here. And one is the credentialing and privileging. There's always some question about perhaps the privileging of the provider involved in the claim and the actual clinical competence of the provider, which gets at the question of is the health center doing a good job privileging their providers to do what they do. There's always issues that come up around medical records. If you don't have an electronic system, you have legibility, the number one issue. There was a case that was settled because the chart was illegible. That was a fact. And there was just nothing to do. There was nothing that the lawyers could do about it. Nobody could read the chart. Signatures, there was another case that was there is no one who could tell us who signed the note. There was a particular note or notes in question, and no one at the health center was able to distinguish whose signature was on that chart. And no one would take ownership of that note either. And that made that case much more difficult than it had to be. So medical records can have an enormous impact on the ability to defend a case, regardless of whether the care was met standard or not. Availability, that's been a problem sometimes. If you have a medical record, it's useless if it's not available when a patient comes in. Moving towards electronic medical records will solve a lot of the problems and will not solve all of the problems. It will make things like availability and legibility no longer issues. Yeah.
Usually hospitals have a policy that if you do a telephone order, you have to sign within 24 hours. We don't have any policy for checking our chart. Like sometimes we do the same day, sometimes we don't have time. And it waits for at least the next day because the practice has changed. It has more patients as compared to like 10, 12 years back, we have enough time to do the. So does it put us on risk if we don't do the chart or lab right away?
The longer you wait, the more risk there is. Yeah. It's not at like 1 day, the risk point, or 2 days. The longer you wait before you complete your chart, the more you're increasing risk. Of course. And the health center should have a policy on that. That the medical staff agrees with. And a policy that nobody agrees to is not a very good policy. So I think if you're going to have a policy on completion of records, it should be done with input from the medical staff. We had a couple of, and it seems to come up a lot of cases. We've got a lot of cases around birth injuries. 25% of the claims that arise are OB related, and 50% of the payments are OB related. So it's an important focus. It's where most of the loss occurs in this program, and you're constantly seeing questions about the existence and/or use and proper use of protocols. And in the OB arena, there's a lot of protocols. ACOG has got a big, thick compendium of stuff, and we should be using those protocols where appropriate. And we're finding cases where they're not being used. That we're not finding failure to follow these recognized protocols in OB. And next is informed consent. There's always some issues around informed consent. With our patient population, it's probably more difficult than with others. We have to speak many languages. And we've got to be sure that the patient understands what we're proposing in our treatment plan, and be sure that we're actually getting a consent to what we're proposing. Okay, so we've got to remember that informed consent is not just getting the patient to sign a document in their language. It's It's a little more than that. It's a conversation and it's a permission from the patient. And the patient got to understand what you're proposing.